Hello and welcome back to the PSC In Conversation. I'm Harris Laurie, an associate partner at the PSC, and I'm delighted to be joined today by an ex-colleague and friend of the PSC, Makoto Nakajima. So it's lovely to have you with us, Makoto. Why don't you introduce yourself and tell us a little bit about where you are today as well?
Thanks, Harris. So I used to be at the PSC for 5 years and looking back, specialized in delivering projects with mental health. And I continued to kind of embark on that journey of making sense of what does it take for people to heal within systems, outside of systems. And so currently I'm on a bit of a long-term life sabbatical, exploring the world. And I'm recording this from a remote island in south of Japan, living in a forest, basically, and a little hut. So excuse my insects in the background, but hopefully you can hear me throughout.
We hear you loud and clear, and we're always proud of all the cool stuff that our alumni go on to do. Whatever it is, they're making a difference in one way or another. Well, in this next episode of the next 20 podcast series, we'll be discussing ending out-of-area placements in mental health. An out-of-area placement is where somebody is placed in a mental health inpatient bed. They might be detained under the Mental Health Act, they might not be, but they're mentally unwell to the extent they need to be admitted to hospital. But there is not provision locally for them to go to hospital, so they have to go to a hospital, often miles outside of their local community where they're living. And that's really bad because it's poor from a patient experience perspective. People are far from their family and friends. If they go on leave as part of their care, then they're really far from their local network. It's also financially ruinous. The cost for an out-of-area placement per day is at least £700, which is approximately double the cost per night of an equivalent stay locally. Root causes of this, sometimes people have really complex needs, don't they, which might mean that they need to go out of area, but more likely it's because there are insufficient numbers of beds locally. And some of that is structural. The number of inpatient mental health beds nationally has steadily decreased over the last few decades, which is an admirable aspiration, but demand hasn't come down in a proportionate way. But much of it's also operational. We've got insufficient throughput of patients in inpatient beds, so they're staying longer than they need to, which is both not great for those patients themselves and also gets in the way of new patients being admitted who really need the bed, which can then lead to them being placed out of area instead. What do you reckon, Makoto? What would you add to that about the poor experience of out-of-area placements?
I do think it's worth reflecting on the terminology itself of out of area. And I think thinking back to this project in retrospect, I was really struck by the importance of the relational dimension. Out of area really speaks to kind of out of being, in the vicinity of where people belong. And so it really creates this distance between people who are receiving care to those who are providing it, and also creates a distance between the staff who are offering care for patients and service users as well. So I think from this relational individual standpoint, it really speaks to this distancing that has a huge impact on that kind of human level, which often gets slightly potentially forgotten when we everything in operational and clinical terms. But there's something extremely distressing, I suppose, for anyone who's displaced from an environment that they're familiar with. So I do want to keep coming back to that perspective.
Thank you for reminding us of that. It's almost like the physical dislocation of being out of area is mirrored by a certain existential dislocation as well.
Absolutely, yeah.
So it's a real issue. We know that nationally, it's a major issue across the country. There's all sorts of policy efforts that go into this, but it's a real tough nut to crack. And we had to go at helping out Sussex Partnership NHS Foundation Trust with this. Are you happy to talk us through, Makoto, first of all, what we tried to do?
Yeah, sure. I think the PSC's involvement with Sussex Partnerships extended to a 2-year period. The part that I was involved with was the last 6 months. So the overall aim of this program was to use what we called a locally led and centrally supported program that worked closely with frontline staff across the trust to initiate and scale up projects that focused and was evidenced to effectively reduce length of stay for adult inpatient units and also to reduce number of these inappropriate out of area placements. So this broke down into a good handful of initiatives running at the same time, all at various stages of implementation. So some were just about to be piloted, some were being kind of sustained over a longer period of time with a lot of evidence-based building already within the area. But I think it really boiled down to us offering quite a lot of hands-on support and coaching methods to support people who are on the front line to make sure that they felt empowered and confident in making those changes happen amongst the kind of insane amount of pressure that every single person was experiencing on a day-to-day basis to manage with the load of needs they were experiencing across the wards. I guess that's the summary. Harris, what would you add?
That's great. And I enjoy actually reflecting on the kinds of initiatives we helped the teams to implement. And it was fun, wasn't it? Because we ended up working with all inpatient wards, didn't we, across the trust. And what was interesting to me is that it was a mixture of quite detailed operational stuff and also quite thoughtful clinical stuff. And sometimes the two were combined as well. But if I think about that for a moment, on the one hand, we were supporting teams, weren't we, to make sure that their morning get together as a team, what they call the multidisciplinary team huddle, worked more efficiently. They were really focused on what the next action should be for each patient that day to progress them more towards recovery. And that was really quite tight operational stuff that we were helping them to make more efficient. And then at the same time, and therefore it would speed up patients' recovery, leaving earlier from hospital. And at the same time, we were also supporting initiatives like wellness and well-being plans, where one of the psychologists we worked with felt quite passionately that there was a role to play in using elements of other methods she'd used before, but really focusing on what were the kinds of things that patients experience on the ward that made them feel good about themselves, what kind of skills they could draw on. So it's kind of psychologically informed tools, wasn't it, to help patients to build on their strengths. Again, to reduce the amount of time they stayed in hospital in a way because they recovered quicker and therefore were ready to leave sooner as well. So it's that mix of operational and clinical that I found particularly interesting.
Yeah, I completely agree. It was really interesting to tune into the intersection of these two dimensions. And I personally, thinking back, am quite struck by the level of ambiguity and uncertainty that we were working with when it came to embedding new clinical pathways for people with complex emotional needs. There was this sense of unknown almost of what is the right answer actually in providing the best care for this subset of service users. And there was definitely kind of evidence building around a specific way to structure this care pathway to shorten it dramatically in order to tend to very specific needs that these people are presenting. But also at the same time, I think we were constantly in discussion with clinicians about, how do we make sure that it's also not entirely neglectful by reducing the length so drastically. It was such a difficult balance to strike. And I think every team that we worked with brought up different types of dilemmas that were quite specific to the culture of each team. And so the way that we were tuning in to these quite nuanced differences and variations, it was really stimulating. Sometimes, yeah, quite, I guess, ambiguous for us to deal with in terms of knowing how to proceed. And yet, I think we were able to bring this presence, and so, yeah, we were also being responded to with presence from these teams to sit with those dilemmas. Yeah, quite, and look at it quite closely.
I remember we had quite a lot of live discussions between us, Mako, didn't we, about how to manage that tension. As you say, on the one hand, we were very alive to, I needed to be attentive to these nuances, these unknowns, these ambiguities. And at the same time, we had to combine that with being quite, what's the right word? Tenacious and quite enthusiastic and quite driven about scaling up these practices from some wards to all wards and bring people on board with the right mix of perseverance and empathy.
Yeah, and always pressure to deliver tangible changes, I suppose, that everyone was feeling from all angles, while also treading carefully. Definitely a hard balance to strike.
We managed some pretty decent results, though, didn't we? Are you happy to talk us through some of those?
Yeah, absolutely. So if we start with the story of the big numbers, we have some significant results. So compared to the starting point of when the program kicked off in, I think it was around September 2022, the trust was at a point at which they were experiencing about 100 acute bed contracts on a weekly basis, and inappropriate and area placements came up to about 30 per week. And by the time that we finished the program, there was a continued, sustained, complete elimination of out of area placements across the trust. And the acute bed contracts had reduced down to about 50 a week. So it was reduced by half compared to where the program began. So those were significant operational numbers that we hit. And we estimated that in the last 6 months, we managed to generate a recurring monthly saving of approximately £100,000 compared to the financial position at the start of the program. And looking at the process, we engaged with a total of 22 inpatient wards to embed these evidence-based improvement initiatives into their ways of working. So that's a mouthful, but I guess as a pretty big, substantial outcome to reflect on. And actually, what stays with me though, 2 years and a half later, is the type of narratives that came out of the program of work that I recall kind of sharing with the colleagues that we were working with. And it was just a story of sustaining meaningful momentum for impactful change, and also a kind of reclaiming possibility from individual efforts from the front line. So the importance of sustaining momentum for impactful change was kind of the key focus when I joined the program in the last 6 months. And it's often the phase that gets quite easily forgotten from transformational programs. So there was a real emphasis on making sure that there was this continued, I guess, drive that we are seeing across the trust. And it's, I suppose, less drastic compared to the initial reduction, but there's something that is so worth celebrating when we look at the graphs and how kind of consistent these eliminations were over a longer period of time. And in regards to the reclamation of a sense of possibility from the frontline staff, I think it was possibly the most embodied change that we got to witness. It was through this direct interaction with the frontline staff that we were working through the projects. And like you said, Harris, it came from these initiatives like the positive wellness plans, where they were talking about creative ways to engage with service users, um, all the way up to engaging with a very kind of diverse team of staff coming from all the different parts of a pathway. But just thinking back to the context, amidst a very, very challenging situation where people were constantly snowed under from pressures for crisis management, these projects seem to nurture a sense of possibility and spaciousness, where they're actually being able to notice, oh, these little changes that we're making, when continuously delivered through collaboration, we can actually make a difference and take those steps at a time towards a better direction, where in moments where it can feel extremely, I guess, hopeless at times. So I really stay with this cultural impact that I personally experienced, and I think you experienced as well, Harris. So I do want to look at the mixed method kind of impact that we made.
When we talk about cultural change in organizations, I'm never convinced that comes from lots of hand wringing and lots of meetings to discuss the fact there was a cultural problem and what we're going to do about it, but normally actually is made better and ameliorated by doing stuff, it might be quite small scale stuff. Although our stuff wasn't small scale, it started small scale, but then got much bigger. But that was what created a sense of possibility and enthusiasm, which then led to a more positive culture. But it was the action that drove the behavior and mindset shifts, I think, rather than the other way around.
I completely agree. And also, it's just how people show up to these conversations about action as well. And I'm kind of jumping ahead to something that I want to share when we come to a future topic, but I think just a really key ingredient for this type of work is this shared commitment to breeding compassionate, supportive, and proactive kind of way of relating to one another, which was something that we were seeing consistently across the board on in this trust. I think having a centralized program like this kind of sets a certain standard in terms of the type of delivery style. Every person showed up to the conversations and the actual delivery with a certain presence and commitment that I think was, yeah, the key ingredient to success.
The purpose of the next 20 series is to think about what the implications of our work are for the future and for clients grappling with these kinds of challenges, well, now and into the future. You've begun to talk about it there already. Say a little bit more, if you would, about what you think some of the key ingredients were and will need to be in the future for similar pieces of work.
Yeah, for sure. So, in addition to this cultural commitment, I think something that's always pretty key for this type of work that we do at the PSC is a program design that allows for this locally led, centrally supported design. What this means is that while there are centralized decisions made so that we can effectively transfer successful initiatives across a wide range of geographical areas, there's always room for local nuance and adaptation to be led by those on the front line who are designated to be leads from the very start. So there's empowerment happening from both top down and bottom up. And overseeing the program, it felt like we created a kind of a hub where lines of communication and flows of information otherwise would not have happened. Yeah, a beautiful convergence in a way. And I think what felt most kind of memorable for me was having staff from the wards attend weekly meetings that are often exclusive to execs, exclusive to management, to really speak about their lived experience of how their implementation of projects are going. And the information is simple, but there's just a sense of connectedness and sense of, yeah, shared belonging perhaps to a mission that otherwise often can get missed, I suppose, when people continue to work in silos. So we're creating those connections quite forcefully at times, but very effectively, actually.
It struck me that those kinds of meetings that we run, where local teams presented their work and updates to the senior sponsors of the program, as you said, they create a sense of connectedness. And I might build on that and say in a kind of quite reciprocal way, because for the senior folks, they were both there to learn from the experiences of the people implementing change on the ground and to understand more about what it takes. And they were also there to support and unblock stuff where people came up against problems that they needed a bit more of senior heft to shift, I suppose. And on the other hand, the clinicians and operational folks from the frontline teams were there both to present the work that they'd done in support of the trust's objectives, and also themselves found it an interesting learning experience to be in these settings where they also got a sense and flavour of what their senior leaders' priorities were in running the organisation. And in that sense, it felt like quite a reciprocal learning exchange.
Yeah, I completely agree. And I suppose that makes me think that when you're working on a specific service, you often forget that the organization is part of a trust. It's quite an arbitrary um, a frame to think about in terms of what are we working within the context. And so this reciprocation of support really, I think, reminded people that yeah, the parameters of where they're working is actually wider, and there's a reach that they can definitely access way beyond what is visible on a day-to-day basis. And I suppose that's going to become more and more important in the future of the NHS, the future of public services, where there might be, yeah, just an increasing need for creative ways to outsource support and, yeah, share resources across the board.
What did you think about the fact that we called it the Reducing Length of Stay program? That was quite a deliberate decision, wasn't it? Because we wanted to move away from any kind of euphemistic title where everybody knows it's really about trying to do something. We don't want to call it that because you're scared of what particularly clinical folks might think, or is this all just an attempt to save money and kind of, do stuff operationally? And we tried to argue that, well, yes, it is that. And it's also good for patients. It's not an either or. And so let's just be upfront about what we're trying to call it. What do you think were the pros and cons of taking that quite upfront, almost like non-apologetic approach to how we reference the program?
Yeah, it's an interesting question. I guess I'll start with the cons. It is a very dry title, isn't it, for a program that, again, it speaks to a relational dimension. It's much deeper than that, is what it felt like. But actually, I was thinking about this point earlier, and I think, Harris, you're always playing a big role of bringing discernment in from a kind of rational standpoint. Because what happens is when opportunities for changes at a whole system level arise, it's very natural that teams bring in a big wish list of possibilities. And so I think we kept coming back to the title as a way to remind ourselves, hey, this is actually the way that we need to prioritize this time round to make sure that there is direct impact and also feasibility that we can prioritize. So ultimately, I think it helped us massively to, yeah, narrow down our focus. And yet it still felt like we were reaching to, a very, very broad range of initiatives. So perhaps there was space for two titles. I'm not sure, but it did serve a big purpose, I think. What do you think?
Nice. I still think it was the right decision, but I agree with you that um, we we had to do quite a bit of explanation, didn't we, to kind of justify the use of that title. Not to apologise about it, but to explain that the relational and outcome focused care for patients was an integral part of this program. It couldn't be divorced from the operational and financial reality.
Mm.
But if we, to finish off, we're going to do allow ourselves the luxury of thinking a little bit beyond some of the operational, financial, and perhaps even clinical reality that we find ourselves in now. We've talked, haven't we, over the years, a little bit more existentially. What if this all looked very different? What if we reframed our whole understanding of inpatient provision and the idea of placement at all? It's a little bit of a thought experiment, so our listeners will have to indulge us just for a couple of minutes. But I think it is worth considering because there might well be nuggets which might well be relevant even for the very pressured reality that the NHS finds itself in now. What do you make of that?
Yeah, this is my favorite part, as you know, Harris. And I guess I just want to say that these kind of macroscopic inquiries, I think it does go beyond a thought experiment, but as a way of bringing kind of reflexivity into practice, as well as kind of recognizing the reality that there is an international shift happening or efforts towards bringing care back into the community. So I'm aware that there's been a collective acknowledgement of the Trieste case study as the aspirational model for psychiatric interventions across the UK for quite a long time. And they're marked by kind of key ingredients around 24/7 community-based access that is very visible and trusted and localized, a shift to framing risk as something that's shared, and also a very deep integration with the wider social fabric of housing, social care, and the voluntary sector. And it's always been the kind of anchoring model for people to keep coming back to when they're thinking about where is this transformation leading to. But at the same time, there's also a recurring story of need to devote energy to day-to-day operational emergencies. So I think I was thinking about this question, and it speaks to the necessity to anchor hope for improvement and possibility through tangible small steps that are actually feasible to implement. And I think that's what we were seeing arise quite significantly in Sussex as well. So some of the most famous initiatives that the UK is familiar with is the focus on developing crisis cafes and safe havens. So these are non-clinical drop-in spaces covering evening hours and weekends, crisis houses that are alternatives for short-term residential placements that are not inpatient-based. And I think what I've noticed with these trends is it speaks to the importance of third spaces, so places that are not necessarily medicalized or owned very kind of explicitly by medicalized entities, but very community-based spaces and environments that allow for people to bring their distress into and to be addressed in a different way. I found it interesting drawing from international examples as well. So there are also kind of culturally, I think sensitive could be a way to frame it, approaches to bringing lay counselors, often elder community leaders, for example, offering structured conversations, for example, on public benches. So there was an initiative from Zimbabwe called Friendship Bench that was flagship, but then scaled up globally to really shift the way people acknowledge their mental health needs, bring it to different places. And it was shown to reduce symptoms of depression and suicidal ideation at a collective level in a very significant way. I think these examples really remind us that in places that people really find safety in accessing to really address and open up with their distress, it really can effectively shift the way the source demand for inpatient care materializes and across the whole system. And I just want to also wrap up my thoughts here as another reminder to return to relational thinking. So, as I said at the beginning, out of area placements, it really speaks to this distancing. So, what does it take to just simply bring care back closer to home for people to feel this relational proximity to the places that they're receiving care from? Um, and yeah, it really boils down to how individuals relate to one another. Um, and it will have to be at the heart of the evolution in how psychiatric care evolves going forward to the next 20 years, I'd imagine. So this is my ramble, Harris, but what do you think?
Well, always, with all of my work with you, Makoto, very thought-provoking. And it makes me wonder whether it's a slightly perhaps naff use of language, but when we say out of area placements, that is predicated on a model of people with mental ill health need to be placed somewhere. They are placed, as in they are kind of passive, and we as society need to find a place for them. And some of the initiatives and philosophy that you just talked about there suggests that maybe we need to think about almost turning that on its head, so that society more broadly is placing itself alongside people in distress. The responsibility is to place ourselves alongside as much as it is. Of course, there'll still be need to place in some instances, but if we can place ourselves alongside perhaps more, that might be one way of describing some of this move that you've referred to.
I really, really love that. I think that kind of radical shift semantically can make a big difference over time in terms of how people make sense of this dilemma.
Well, we covered quite a lot there, Makoto, quite a lot of ground. Thank you so much for being with us to reflect on our work with Sussex, our reflections on that, what we think that means for the future. It's been a real pleasure. Thank you.
It's been really thought-provoking and so nice to speak to you again, Harris, after all this time.
Well, this has been the PSC In Conversation, and thank you so much for joining us.
Thank you. Bye.